Okay, well, welcome to this Pharmacology drug class review on the anti-diabetic drugs, specifically giving some focus and attention on the GLP-1 receptor agonist. Now, this drug class has been huge for us as clinicians in the management of both type 2 diabetes and obesity weight management. Now, we all know that type 2 diabetes is linked to weight and obviously development of insulin resistance, so that's helpful. This clearly makes these agents useful when a patient is suffering from both. However, we know that this class is not without its potential problems, especially when used wrong. And with that, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind what we do. That includes pharmacology and the drugs that we use every day. Because when you understand why, it makes the how easier. Those mechanisms start to make sense and predict the therapeutic effects. Many of them also explain why patients develop certain side effects and why we implement certain types of monitoring parameters and then obviously counsel our patients in the way that we do. Now, with all of my drug class reviews that you guys have seen, or if this is your first time, we cover core content. Right? That means we hit the stuff that you have to sometimes memorize. They're the must know, right? And then everything else builds on that. So that's your agents, what drugs make up the drug class, what are their common indications, usage, net benefit. What is the pharmacology? That means mechanisms that translates to that understanding of the therapeutic effect, side effects, monitoring parameters, those kind of things. And then we'll start to tie in that clinical knowledge application, the clinical pearls that I think we all wish someone would just kind of put into some context for us, okay? All right, with that, let's start with the agents, okay? So we have glucagon-like peptide 1 agonists, and this list has grown over the years. I remember when Exenatide came out. It comes out in a formulation that's immediate release, but also an extended release. It was huge. And it's huge because we'll talk about that in the net benefit of what this class has really propelled things along. And so when you have a class that grows like this, then that means usually there's one, money to be made. Number two, there's a need and there's evidence to support their use, okay? So we have Dulaglutide, we have Exenatide, Liraglutide, and then Semaglutide. When you look at the Exenatide, this drug in particular by itself is less available. It is more commonly seen in combination. Okay, now let's pivot over and let's look at some of those indications and common uses of the drugs that we'll see in clinical practice, recognizing that, as I just said, these drugs are just growing and their evidence is growing. The data is supporting them, and the little areas and nuances where they work and offer benefit are continuing to grow, and that's okay. That happens with a lot of drugs that we use, especially in this particular disease state, which has every year new guidelines, new updates, new data. There's a lot of investment because it's a huge, obviously, public health issue. So one of the things I put together for you, and I like to do for myself, but also hopefully it helps you as well, is tables, right? Graphs, tables, images, things that help us wrap our minds around one agent over another. Sometimes it's even by formulation. We've seen that in different drug classes over the years, where a specific brand name product or formulation has a specific indication or primary use based on evidence, the way the drug was studied. Maybe it's the way the drug is released in that particular disease state compared to other disease states. All of that matters in the context of clinical application, but also from the practical parts of being involved in the healthcare system. What I mean by that is insurance companies and preferred drug lists and things like that have criteria for how somebody gets on a particular drug, and sometimes a specific dosage formulation. And so your documentation, the appropriate diagnostic codes, things like that get put in our notes, guide us to that. Well, this table is available for you for free download at thisiswhy.health. That link to this topic is available in the description for the video, or if you're joining us on our podcast channels like Spotify and Apple, then you can see that in there, and you can go to the page at thisiswhy.health to download these for free. Again, use them for study tools, share them with your friends, colleagues. If you teach precept, feel free to use them. That's why it's there. So it's not just to help me wrap my head around all these things, especially if they've grown, but hopefully in helping us to understand and apply the information. So what you see here in this table, especially those of you joining on the podcast who can't see it, that we have a number of columns, and each row represents a drug name and formulation, and sometimes the dosing recommendations for that particular indication. And then as we go across, we have the brand names, again, the dose limitations, and then the uses or FDA approved uses. And I might say in uses, that doesn't mean they're all FDA approved. And I think this is going to continue to grow. So depending on when you listen to this lecture, you might be like, oh, technically, there's supposed to be a check mark here. You forgot that, or it's... No, listen, guys, these drugs, the lines that are becoming more blurred between them. I'm not saying that doesn't mean that there isn't separation between them, okay? We need to be evidence-based clinicians practicing around the evidence itself, okay? That's what protects us. It's also how we should be practicing in general, because we've seen in drug classes where a particular agent inside of a group of agents doesn't always do the same thing as the other agents, or may have a problem, okay? We're going to see, like for Exenatide, people form antibodies against it, right? And it can impact things. And so those subtle variations between the agents do become important, but the lines are blurred in many areas. Now, with it, as it relates to type 2 diabetes, you can see that, man, across the board, that's what these drugs are used for. And then, of course, with patients with type 2 diabetes, we know that they typically follow this triad of hypertension, dyslipidemia, weight problems, usually metabolic dysfunction that affects the liver, because with the dyslipidemia and the insulin resistance, we have fat deposition that also occurs in the liver. And that's where MASH, is showing up now. And more of these drugs are probably going to have more evidence in their use in helping that condition, because when you have all that fat deposition and the insulin resistance and the milu gets created, you just cause a lot of inflammation, irritation to that intrahepatic tissue that then sets people up for chronic inflammation, scarring, fibrosis, and eventually going into, if left untreated and uncontrolled, all the way down to liver disease and failure. And so you'll see that the check marks with MASH are limited. You'll see the check marks for weight management are limited by specific dosage formulations and doses or max doses that we use, okay? And so I just put that out there for you to make sure that you understand these tables in their context and in the time frame of when you listen to this, and also the evolution of the drugs. But what's great about these drugs is the net benefit, and their expanded use in clinical practice, I think, is good. Okay, so now we're going to move into what is the net benefits. Why do I pick this drug class? You've seen that there's a lot of agents. I've been highlighting it, kind of stressing its importance, providing some context. But why? What's the big deal? Why is it growing? Well, when you look at glucagon-like peptide, okay, this is something that we make in our bodies. We endogenously produce incretins, basically. And these help us to regulate glucose homeostasis, but they also work in other tissues. And there's a balance between organ systems that once you study these and you see these drugs and you apply them over time, man, it's amazing how one organ system affects another organ system. There's the whole brain-gut connection, right? The microbiome and all these things that do play a role in other organ systems. So we can't only think of this molecule or this drug only working as it relates to the pancreas or glucose. It does some other things, and that's what's important. Now, as it relates to insulin, okay, because remember, this is type 2 diabetes. The patients are making insulin still. And we want to preserve, listen, we want to preserve their pancreatic function as long as possible. Otherwise, we would facilitate potentially with certain drug therapies like secretagogues, sulfonylureas, meglitinides, that increase the work capacity of the beta islet cells in that pancreas and literally wear them out, where the disease progresses, and so you don't see sustained A1C reductions. But with this drug class, you get increases in glucose-dependent insulin secretion. That's huge. That's what our normal physiology does, right? We have, yes, a little bit of glucagon, and we have insulin, and there's this basal amounts that are occurring, again, to keep the glucose steady. And then when we eat something, then there's this response by the body in a glucose-dependent manner. That's appropriate physiology. So these drugs help to augment, mimic that activity, strengthen it, okay? And that's good, and it facilitates improvements in cardiovascular health, weight loss, which reduces that insulin resistance that feeds back into that metabolic dysfunction associated with steatohepatitis. All of that together, but you see this nice drop in A1C from a multifactorial perspective, because it also affects gastric emptying, right, at some level. And so this is where some of the benefits of weight loss come from, that then correct as we reduce caloric intake, improve the A1C. So you're not even improving the insulin release, but you're improving the A1C because you're losing weight and you're reducing caloric intake. I mean, in many respects, we're getting to the underlying problems of type 2 diabetes, and that is important. And secondarily, the A1C reductions are sustained. That is key. Where we didn't see that with sulfonylureas and meglitinides, we could get up to 2% reductions in the A1C with sulfonylureas. That's what the evidence would say. But it's not sustained. Their A1C starts to creep up over time. Why? Because we're wearing out the pancreas. Like, it's literally just short of breath and dyspnea. I mean, it just dies because of overuse and overactivity from these drugs, constantly stimulating them and never giving them a break. So that is the overall net benefit of this drug class, which explains why this class has grown and why they are recommended more so nowadays compared to other drugs historically. It doesn't mean metformin and those drugs have any bearing whatsoever in clinical practice. They still have a value and a place. Not everybody can be on these. There are reasons you shouldn't consider them in certain patients. Sometimes it's also cost and access. So cost-effective options that we have available to us are important. Okay, now I'd like to begin to now pivot over into that mechanism, the pharmacology. You know, I've already a little bit alluded to some of this already, okay? Now, GLP, okay, we're mimicking that hormone, right? That glucagon-like peptide 1 hormone. We're increasing the effect of glucose-dependent insulin secretion. You're like, well, if you actually look at the pathophysiology of type 2 diabetes, these patients early on in their disease are making large amounts of insulin. Why? Well, because remember, they have insulin resistance, so they need more to overcome the resistance. Well, that wears out the pancreas over time, right? But so we want this to be in a glucose-dependent manner, and we want to make the resistance less so that we improve the overall efficacy of the insulin being secreted and its effectiveness on what it's doing in glucose homeostasis. But it's also helping to regulate other things. Remember, I said they don't just work in one organ system. These things are injected in our bodies. They're systemically floating around, right? And so they get into the blood, and they're going to exert their effects in different areas. So we have an effect on glucagon secretion. Remember, glucagon, when it gets released, is trying to raise the blood sugar, so we decrease it with this medication. That improves our blood sugars, right? We increase the sensation that we're full, so we reduce our oral intake. That reduces our caloric intake, which reduces weight and improves our glucose. And then lastly, that's that gastric emptying. And this is where food will sit there longer in the stomach. You will feel fuller for sooner, and so you will consume less. If you try to consume the same amount you might normally consume when you have administered this medication, you might find yourself in the bathroom, right? Nausea, vomiting, unfortunately. Okay? If you titrate it inappropriately, your body doesn't acclimate. This can slow down peristaltic movements and gastric emptying so much that patients I've seen them come in the emergency department with significant uncontrolled nausea, vomiting. And some of these drugs are like injected and last a week. There's a condition like that you've probably heard about, frozen bowel syndrome. Like it's frozen, not temperature-wise, it just doesn't move. And so it just sits there. And these patients are extremely uncomfortable. Well, I can't just kickstart it. There's not an antidote to reverse it immediately, right? So this is a very difficult condition to treat when patients don't use the drug right. And we don't understand the mechanisms to understand why those side effects occur. So this is why, no pun intended, why I talk about this and why understanding the underlying reasons is so relevant. Okay, now that I beat that to a pulp, but it's important, guys, right? I don't want you memorizing things. You're not going to help people. You're not going to be competent clinicians memorizing facts. It's not the way it works. And if you're a good test taker, your patient does not present to you in the clinic or the hospital, I don't care where, as a multiple choice question. They present as a human being with real comorbidities, real issues, real factors that we have to implement at real time to achieve our goals with them. So when we think about these drugs, we need to think also their pharmacokinetics, not just their dynamics, what happens to the biologic effect, the mechanism, but there's also the half-life of these drugs, and then there's the titration. Remember, you want your body to acclimate. I mean, we do the same thing with other drugs too, like antidepressants for depression, anxiety. If you start out at the max effective dose, you could cause somebody to go into a full panic attack. Right? So you allow the chemistry, the biology to calibrate itself under the influence of something that's really already been there. So like serotonin and depression, GLP-1 is present. It's one of the incretins that we have present. Right? We're just now changing the concentration or influencing the receptors differently. And so the body needs to go, okay, I see that. Let me kind of pivot and turn on and regulate some other activities. That allows us to get to those goals and allows us to achieve the desired therapeutic effect without the patient suffering severe consequences. So that requires us to counsel the patient. You can't counsel the patient if you don't understand this and you don't know how to dose it correctly or you don't stress it right. I mean, I've had patients come in who's literally like, these are people wanting to lose weight, like they're Americans, so they think more is better. If I take one vitamin, I should take two. Well, don't do that with this. Because again, you will freeze your bowel and they just won't work, right? And so it's very difficult. And so you'll see here the efficacy in time is different from different formulations and agents here. These are things that you just need to recognize. Again, it's splitting of the hairs between the agents, okay? Exenatide, extended release is 6 to 10 weeks, right? Semaglutide, sub-Q 4 to 5 weeks, okay? Now, what does all this have to also do on the pharmacodynamics and kinetics of other drugs? If you slow gastric emptying and you slow gastric or intestinal motility, you are also going to affect the absorption of other co-administered drugs at that same time. And so you just need to realize that. Now, some drugs do have a time-sensitive absorption profile. That may influence the overall net absorption or the overall bioavailability. So it's just important to keep that in mind, especially if it's a time sensitive. Think about drugs like clopidogrel bolusing in doses and things like that. If you're using the oral route, right? Because clopidogrel is not available parenterally. Okay. All right, so with that, now we're going to transition into a few more clinical application, the knowledge, like where does this, we talked about mechanisms, indications. Let's dive into like the place in therapy in the context of other drug therapy out there. Now, this is not meant to be an exhaustive review of every patient care scenario. That is not what we can do here. You need to have the core foundation so that you can then build upon that. When you read the guidelines, when you apply them into position statements where you're applying to your patients, you're trying to apply it in the context of the evidence. Okay, so with that, let's dive into places in therapy first. Okay, secondary benefit considerations. Cardiovascular risk reduction is huge, okay? I mean, this is massive because we know this patient population is already at greater risk for that, okay? There's obviously, as time goes on and evidence, depending on what study was done and this, that, and how much money is going to be invested in marketing and trying to get an indication, all these things. Many of these drug companies are looking for off-label use. And they assume, kind of like with the ACE inhibitors, that people will use them and extrapolate the data beyond. Now, is that right? No, not necessarily, right? Ramipril from the HOPE trial didn't get all the credit, so we use a lot of other ACE inhibitors and we extrapolate the HOPE trial data. But so that stuff happens, right? But this is a huge, huge area, right? And so Liraglutide, Semaglutide, Dulaglutide, all those agents considered first-line options, irrespective of metformin. And the reason that statement is in there is because historically, in the last several decades, metformin played a central role. It was a very cost-effective, evidence-based intervention that worked without also causing disease progression. And it's available orally. Right? So it's very convenient overall, fairly well tolerated when used appropriately, right? And so these drugs, irrespective of that, should still be considered in someone with concomitant disease states like cardiovascular disease. And that is the main take-home point that I want you to walk away with, because it doesn't mean metformin has no value. Metformin does have value and should still be considered in certain patient populations, in certain situations. But just recognize that these drugs go above and beyond that, right? Chronic kidney disease. If patients cannot take one of the sodium glucose transporter 2 inhibitors, SGLT2 inhibitors, then, and if that's not an option for them, or they have fluid overload problems, right? That's where you should consider those drugs. They're very helpful for that. You get the control of the glucose, but you also benefit from fluid management and with their other comorbidities. Then a GLP-1 agonist, especially for cardiovascular benefits in these patients, because we know that CKD is also one of those basically independent risk factors for cardiovascular disease. Right? We should not ignore it, kind of like type 2 diabetes. We need to be very aggressive. Weight, overweight, and obesity. This is obviously huge. It's had a profound impact on many patients' lives and improving a lot of comorbidities and their disease states as long as they continue to take it, obviously. That is probably a little caveat. And then MASH, right? This goes back to all these things that I just covered are indications, aren't they? That's the place in therapy, okay? But these drugs have demonstrated some benefits in patients with MASH. Again, metabolic dysfunction associated steatohepatitis. Hepatitis being inflammation, irritation of the hepatocytes in the liver. Why? Because of stuff that's not supposed to be there, usually fat deposition. That's where the older term non-alcoholic fatty liver disease, right? We had NASH and non-alcoholic fatty liver disease, NALD. Like those terms have evolved. I get the changing in terminology. Don't get hung up so much on that rather than understanding the underlying problems going on. And so these patients develop these metabolic dysfunctions that extend beyond just the liver. It affects the blood vessels, it affects the lipids, it affects the kidneys, eyes, nerves. All of it starts to compound, which is why we're so aggressive at trying to get these patients under good control. Now, if we take those indications and those specific areas of use, and we now put them in the context of the larger treatment of diabetes. So I have a couple tables here that are just, again, snapshots. I'm not going to spend an hour talking about them, but they're available for you at thisiswhy.health for free and download. But this table here that I'm talking about is just the general treatment. We have type 1 diabetes and we have type 2 diabetes. And I said that many of these drugs are being obviously used preferentially in type 2 diabetes because of the underlying pathophysiology. Type 1 patients don't have functioning pancreases with beta cells that make enough insulin, so you have to replace it. And then you see, obviously, Pramlintide. Right? Of course, this is all on top of medical nutrition therapy and also physical exercise. We'd never want to negate those value points. But this is where we're down here in this bullet where we have monotherapy or combination therapy with non-insulin based therapy. Why non-insulin based? Well, because insulin, unfortunately, like other secretagogues and insulin, can cause weight gain. And so we don't want to do that if we can. We also want to use drugs that create multiple benefits to the patient. So if you can lose weight, improve steatohepatitis, get the A1C under control, you might even see patients' blood pressure needs for medications drop. I mean, all of that compounded screams benefit. And that's where these drugs are fitting in the type 2 before patients have to go on to insulin, which then works. It works great. Insulin will get you under control, but it will also cause side effects, potentially hypoglycemia, which these drugs don't, usually do unless there's other drug situations on board, right? So we have then, when we think about our drug therapies, right, our non-insulin therapies, we have two sort of subcategories, these secretagogues and non-secretagogues. I've already talked about secretagogues being those drugs that are going to facilitate and stimulate the pancreas to release that insulin into circulation to facilitate, obviously, better control. Well, eventually you're going to burn out. It's like you running a marathon and someone at the end of it saying, hey, you need to run, and by the way, you got to run faster, and you can't stop. There's no breaks. That's what sulfonylureas, unfortunately, because of the long half-life, do. And meglitinides, while they have a shorter half-life, try to reduce the burnout and create more of that glucose-dependent effect when you take it around your meals. The problem is these drugs just continue to exacerbate the pathophysiology of the disease. They do get initial A1Cs, but they don't get that control. So that's where the next table, which are the non-secretagogue agents that are non-insulin based treatments, this class, these subgroups have just grown. Right? And certain groups you can see that have the highest number of agents in there, right? The DPP-4 inhibitors, GLP-1 receptor agonists, you have the SGLT2 inhibitors. Man, these classes have just, because of their benefits on other comorbidities that seem to coexist in patients with this metabolic problem, right? And so our GLP-1s right here, and we do have a GIP, right? GLP drug, Tirzepatide. That's up here. We kind of put it in its own class because a lot of people do separate it because of its dual mechanistic properties. And I think those evolutions are probably going to happen as well. And you'll see that continue to grow. Again, they're modulating the degrees of these incretins in our body because we see where their benefit, and there's also the potential negatives. But here we are. This is where this drug fits in as an option. So you should have, when you have your box of tools, you should know and understand, why does this tool work over that other tool? What is the mechanistically different? And that's why learning these things in that context is so important. But you also see them in the context of when do you use them, when do you not use them? So some of this was already being reinforced a minute ago, so I'm not going to spend that much time here. But this table lists in each row a medical condition or problem, and then drugs that you should think about. I'm not saying absolute, but think about applying to the patient. And then there's also on the far right column, drugs that we should avoid or use with extreme caution with those comorbidities. And so you see that there's generic classes listed there to kind of give you that framework, that snapshot to wrap your mind around. This is stuff that's at the core of exams, board questions, those kind of things, but they're also very relevant and applied clinically. So when you have a table like this that can serve multiple purposes, in my opinion, obviously I'm biased, I made it, but it helps me. It helped me in my own training, and so I want to share it with you if it helps you. But you'll see up here we have GLPs in patients with obesity, right? We should consider it. Patients with CKD, especially if they can't take an SGLT2 inhibitor. Okay, those are important. You see heart failure. Again, especially with fluid overload, if you can use an SGLT2 inhibitor, that's probably helpful to them in that condition along with your diabetes. But you see that we should consider GLP-1s in multiple comorbidities. That's just consistent with what I just said earlier. But where do we avoid them? Again, it's how you use this table. It's right here with patients with gastroparesis. They already have maybe diabetic gastroparesis and they suffer from very poor emptying and they get nauseous very quick. They may not be a candidate. So you can love this drug all day long. It could be the most highly recommended drug all day long. It can be the most studied drug all day long. But if it doesn't fit best in that patient because of other comorbidity like gastroparesis, you're not helping the patient, right? That is pharmacotherapy, okay? Down here you see pancreatitis, these drugs. Any drug that raises the incretins or functions like the incretins seems to have this risk, okay? Now, does everybody get it? No, but it's a risk. Also gallbladder problems, okay? We'll see that here in a minute. And then lastly down here is the risk for tumors in the thyroid gland and patients with specific histories. You just got to know that for your own protection, okay? All right, now what I want to do is, we talked about place in therapy. We have where it fits, this drug class fits in the overall management. Why do I pick it? Maybe groups that I don't. I'm going to reinforce a few things here over the next couple slides. It just to fine-tune some things. So I mentioned earlier about the titration. This is one of those clinical pearls that is huge. And again, we have different formulations. We even have an oral option now of semaglutide. So when you have these different formulations, the way we use them and the ability to titrate is influenced by that. For example, Exenatide, it comes in immediate release, but also an extended release. But the extended release doesn't give us much option for titration. Now, so that's sometimes where you start out with one and then you convert to another, which is what we did in the, back in the day when we didn't have other options in this class when it was still growing, But you want to start out at the lowest effective dose and you want to titrate to achieve that desired therapeutic effect without compromising the risk of these adverse drug events. Now, oral semaglutide, again, it's nice because some people don't like to give themselves injections or they can't remember once a week, even though that seems beneficial. But when you have to do something every day, it tends to become part of a habit, doesn't it? Right? So, and that's nice to have options for patients based on their particular preferences or lifestyle. Now with this one, you are going to titrate. Okay, so we started out at 3 milligrams dose. That is not the therapeutic dose at all. Okay, but it's the starting dose, and we're doing this again to improve GI tolerance. But even how you take it. So this is a huge counseling point. How you take it. We need this drug to be in contact with the lining of the stomach to properly be absorbed. So even too much water. Right? Everybody thinks like more water is better. At some point, too much water will kill you. There's nothing in it, right? No minerals unless you have modified water, right? You drink smart water and things like that, right? That have other things in it. But the reality is we recommend that less than 4 ounces of water and no other food or drinks or medications within 30 minutes so that we maximize the reliability, predictability of that drug. So that's a pharmacokinetic consideration that translates into a meaningful counseling point. So just keep that in mind. And also dosage formulations don't always say you can't just double up to try to mimic another dose. Everything needs to be used in an evidence-based, obviously, manner. If you start on one agent and you miss a dose or you need to change or adjust, well, it's influenced by the dosage formulation first, okay, don't forget that. But with the longer acting options that we inject once a week, you need at least probably a good 3 days, of transition between doses before you make modifications to something. Again, you don't want to accumulate, drugs or cause side effects. I mentioned a little earlier at the beginning about combination products. I simply only just wanted you to recognize that this may also continue to grow. It makes perfect sense. You're treating multiple comorbidities, and you want to make it more convenient for patients. And if you can formulate them, or the pharmaceutical company can formulate them, man, I think that's a win-win for patients having, especially if they're on multiple injections and things like that. It just becomes a nuisance, doesn't it? So if you can do things to maximize the overall compliance adherence to their disease, you're going to get the desired outcome, right? So these are our basal long-acting insulins that are combined and available for patients. So contraindications, warnings. I mentioned this a few minutes ago, this issue with thyroid cancers, and there's really two subtypes that are in there, and you have to ask, you should document it if you initiate at least once at baseline. Is there any family or personal history of medullary thyroid carcinoma, or MTC? And then the other one is the multiple endocrine neoplasia syndrome type 2, MEN2, okay? Those we need to keep on our radar, and it's also on a physical exam, because you should be palpating the thyroid gland, feeling for nodules. So part of your follow-up and monitoring documentation technically should include no, sensations in the throat, or compression, changes in the voice, something like that that would compress on the nerves around that area. And so just keep that in mind as you use these drugs. Now there's other ones here like gastric emptying, so patients with gastroparesis, if they have gastric bypass surgery, right, there's a risk of not only dehydration, where you can cause an acute kidney injury, but also risk of, we'll talk about here, a risk of pancreatitis and gallbladder problems here in a minute. If they're going through surgical endoscopy related procedures, there's a chance of aspiration because they're not emptying things out. So you need the provider, the gastroenterologist typically who's doing that endoscopy, wants to know if you're on them. So it's important that patients be counseled that they tell other providers that they see, even if they're not managing that drug, hey, by the way, I'm on this drug and I was supposed to tell you that. All right. Surgery is an issue because, again, anesthesia, all that stuff, the bowel changes post-op, and so patients can be very sick, and it delays dispositions and healing and causes pain and suffering. There is a risk of, or at least a warning for suicide ideations and behavior likes. And so patients with previous attempts or suicidal ideations probably are going to avoid this. Again, one of those documentations to protect you. Does it really cause it? I don't know. There's a lot of confounders that go on in people's lives with chronic medical conditions that play into that as well. Hypoglycemia. Remember, these drugs are working in a glucose dependent fashion as it relates to insulin. So the risk is low, just like with metformin, it's low. Okay? So these are not secretagogues that typically put people at that greater risk. Now, if you are co-administering these drugs with insulin, okay, or a secretagogue is on board, and you now decrease their glucose intake, right, or caloric intake, then the timing, and based on the kinetics of other drugs, it could be expecting a certain amount of glucose, but it's not there because this drug class has prevented you from consuming it. So you may need to reduce the dose of insulin or reduce the dose of some other secretagogue, like we would see with Liraglutide in patients with type 1 or type 2 diabetes that want that tight control on their postprandial glucose levels. So that's where it becomes relevant. Antibodies, this really has more to do with the structures and Exenatide in particular. And Exenatide, these agents, when you look at the structure, the peptide structure, I mean, that's why we have to inject them many times, because we have to bypass the GI tract to protect them from the acid. And so if you are stimulating that receptor with it and you're replacing it as a peptide, then acid's going to cause degradation. So as a result of a peptide being in the body that's not from you, okay, you then cause the immune system to say, oh, I don't know what that thing is. It's not me, though. So I'm going to create an immune reaction so that I can attack it the next time I see it. And so again, when you form antibodies against a drug, which this happens a lot to a lot of drugs, monoclonal antibodies and other things like that, other peptide-related treatments that have to be parenterally administered, we will form antibodies, and that can then create secondary problems. Now, going back to gallbladder disease, going back to the pancreas and the pancreatitis risk, there are a couple things that are important to recognize. We don't know fully yet exactly why all this happens, but there's thoughts that maybe these drugs, again, remember they're working beyond just the pancreas. They're working in the GI tract. They work in other gastrointestinal organs. And so when it comes to the gallbladder, there may be some proliferation and activity of the cholangiocytes. Well, in that process in the biliary epithelial cells, in there can augment the release of the bile. And if it doesn't get out, then you can have backup and intrahepatic effects, and also even precipitation that forms stones and or irritation to the liver. And so we see this in patients who are on higher doses, longer duration, and who have experienced more significant weight loss. We see that with other weight loss options too. Quick, sudden changes in weight can increase that risk. Now, the pancreas, again, is thought to maybe cause some hypertrophy of the cells in the duct, and that would then occlude or change the luminal size so they can't drain the pancreatic enzymes. And so the pancreas and the pancreatic enzymes digest itself instead of being in the intestine where it's supposed to work. Now, keep in mind, we're using this in a patient population with metabolic complications where they have dyslipidemia, where one of the primary lipoproteins affected are the triglycerides. And so hypertriglyceridemia, okay, can be an underlying confounder or component to the cause of the pancreatitis. But as again, you get these diseases under control, those things typically go down as well, the triglycerides. And so alcohol use, obesity, already a known history of cholelithiasis, which in the common bile duct then can back up things even in the pancreas and cause problems, could be part of the reasons why. Now, the effects on the kidneys, that AKI that I mentioned earlier, really comes down to when we're having patients that are nauseous, vomiting, they have volume losses, they develop maybe obstructions, and maybe the bowel are trying to get around these obstructions because they have frozen intestinal components, and they lose fluids that then impair perfusion to the kidney. Diabetic retinopathy, again, this is hypothesized maybe due to sudden shifts and changes in the glucose amounts in the body, and with that, that also causes shifts in fluid. And so there's some hypothesis as it relates to that. And then lastly, or moving closer to the end here, where there's drug interactions, anything that delays gastric emptying or intestinal motility can affect transport, absorption, overall oral bioavailability. Oral contraceptives have been one of those things that is mentioned that you may need to give consideration, may reduce the efficacy of them, and obviously cause escape ovulations. Now, monitoring parameters that are worth considering. Obviously, we want to get baseline A1Cs because we're going to be treating diabetes in most cases, right? And we're going to see that A1C drop. So every 3 to 6 months, you want to make sure they get to their goal. We don't want to wait a year. Once you've achieved stability in the dosing regimen, they've gotten to their goal, you can start to stretch out or reduce the frequency of monitoring that. What about the CMP? CMP stands for Comprehensive Metabolic Panel. And that gives you not just only the electrolytes, but it also gives you the liver enzymes and other test factors that look at liver function. So things like AST, ALT, ALK Phos, those are your liver enzymes. Your T-bili and things like that, INR and albumin and all those things are important. Sorry, INR doesn't come with the CMP. But the albumin and those kind of things become relevant to understanding the functional capacity of that liver, especially if they already have fatty liver. Okay? But remember, that's okay. We're wanting to, we want those liver enzymes and LFTs so that as we implement these treatments, we want to hopefully see that they're improving. In many cases, they are. We see the same thing with statins. When we reduce intrahepatic cholesterol, we do the same thing. Thyroid assessment is huge. It goes back to that, again, risk of thyroid cancer. All right, guys, wrapping things up, the GLP-1s, huge, growing class, a lot of agents, right? Multiple indications, not just type 2 diabetes, but also cardiovascular risk reduction in certain events, especially in patients with type 2 diabetes, weight loss, obesity, weight management, MASH, all that's relevant. A mechanism, remember, it's mimicking the activity of that GLP-1, which then influences that glucose-dependent insulin secretion. Some glucagon effects, reduces it. Remember, gastric emptying. All those are key things that you could see on an exam and obviously translate to the why. Why? Side effects, nausea, vomiting, GI upset, issues like that. Low hypoglycemia risk, okay? So available multiple dosage forms, require dosing titrations for compliance, adherence, and to achieve those desired goals. Guys, I hope that made sense. And in the context of the overall management of this very important disease, I hope it clarified things. If you're an expert, I'm sure there's things that you could probably add to that. And certainly value adding your comments to the section, other pearls, things. We all need to learn from each other, guys. I'm here to try to help you for those that need it. I'm also here to learn and expand my own knowledge base. And while I've been doing this for 30 years, in nursing, pharmacy, medicine, doesn't mean I know everything. So just thank you so much for being here and joining me, allowing me to contribute to a portion of your education and training and knowledge. I'm Dr. Busti, and never stop learning the why, because that makes how we manage patients much easier, and it makes sense, and you're more likely to be effective at that. Also, take a moment, subscribe to us on the channel at thisiswhy.health, and also on our YouTube channel, give us a like. All those small things really do help. I know it seems insignificant, and your time is limited, but we really appreciate it. Thank you so much, and we'll see you next time.